Quick disclaimer. This program and product is supported by the Centers for Disease Control's PS 24-0020 capacity building assistance for HIV prevention programs to end the HIV epidemic in the United States. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by, the CDC, Health and Human Services, or the U.S. government. And I see folks are introducing themselves. Thank you so much. I encourage folks who are joining us to introduce yourselves in the chat as well. Thank you for those who have already done so. Just to give you a little bit of background about who we are, the California PTC was founded in 1989. Over the past 37 years, the California PTC has built the capacity of both international and domestic healthcare providers, forming partnerships with the CDC, the California Department of Public Health, and various nonprofits. As a national prevention training center, the California PTC envisions a society where everyone has access to comprehensive and compassionate health and public health services. To see that come to fruition, we have our mission, which is to provide the public health and healthcare workforce with capacity building, training, and resources to strengthen service delivery. In our work, we focus on structural and individual factors that contribute to health equity, promoting an ethic of compassion, empathy, and humility while tackling the toughest public health challenges like implicit bias, medical mistrust, and racism. Our CEBA program is funded by the CDC to support HIV prevention programs here in the United States. Our free TA is available for CDC-funded health departments, CBOs, and their partners seeking to address challenges related to the planning, implementation, and evaluation of HIV prevention programs, reducing HIV disparities, systemic conditions, and the social drivers that influence health and HIV. This webinar series is part of our TA services. The purpose of this webinar series is to strengthen the organizational capacity of health departments and CBOs to support comprehensive HIV programs to diagnose, treat, and prevent HIV, systemic conditions, and the social drivers affecting health and HIV. So far we have hosted 3 webinars. For today's webinar, we have Jadon Wright Morgan from the Pacific AIDS Education Training Center, who will guide us with strategies to strengthen engagement and retention and care. After the presentation, we'll open up for a brief Q&A, and then we'll have you all out of here by 15 to the hour. If you would like to view the recordings of the past webinar, you can check out the link that's on the slide here. Hopefully our producer can drop it in the chat. Is where you can check out the past recordings of our webinars on demand. So you just click the on demand button once we put that in the chat for you. And Luis, if you're unable to, I'll put it in the chat myself in a moment. So now I'd like to introduce our wonderful presenter for today's webinar. Her name is Jadon Wright Morgan, the Deputy Director of the Pacific AIDS Education Training Center, who will share strategies to increase engagement and retention and care.
So thank you all for joining us this morning. I'm really excited to talk about retention and care. I am working as a capacity building specialist currently, but I was a case manager for a bit of time, a few years, about 8 years, in Florida. And a lot of what I'm going to share with you today, I also experienced when I was a case manager quite a few years ago. And my hope is that we really can talk about strengthening retention and engagement in care. And the retention and engagement really is the foundation of trust, building rapport, and accessing healthcare systems that many people haven't been able to do for various reasons. So there are some best practices that I'm going to share with you as we move through today's presentation. So, as Alshay mentioned, we are also federally funded. We are also doing this in alignment with the administration, but all the views and all the people that I work for disclaim me, and this is purely my presentation. All right, so we're all good there. So, the learning objectives, we're going to really talk today about how do we describe engagement and retention and care. What are some of the structural and individual barriers to engagement? And recognize that some, folks are the highest risk folks are usually disengaged from systems. And so how do we really think about and talk about that? And then we'll also apply I'll share with you some evidence-based strategies to strengthen that retention and care model. All right. So let's start with your experience, right? What are some of the challenges that you all have found in trying to engage people, not in the beginning when they are first diagnosed? That's a whole thing. And I think we had some other sessions earlier in this series that talked about that. But as people have gotten in, maybe they've been diagnosed for a couple of years. What are some of the challenges that you've experienced with retaining those patients in care? I know for me, it has been around, transportation and people moving, housing markets. Um, I live in California, specifically in the Bay Area. We have we have had a transition, where people are moving all over to try to find rent that is affordable to them, right? And so these are some of the things I've experienced as a case manager is trying to help support people through that. And feel free to drop those in the chat if you have any other thoughts about what are some of the most challenging parts for your patients. Another challenge, I also used to work in Florida and we had a donut hole. And there was a Medicaid gap. So, we could we could bill and then there would be this hole and then we couldn't bill. And so that was also a challenge is, changes in insurance and billing was definitely a challenge that I have seen. So you might also think about, stigma is still alive and well with HIV, and that can be a very big challenge. Mental health, substance use, housing instability. We talked about insurance and cost of services. Also appointment availability if people are working, in a job where they have to be there every day, can be difficult to take off for medical appointments. Um, and any others, feel free to add them into the chat as we go along, but I'm going to keep us moving. So, how do we define what is retention and care, right? It's really a continuous engagement. It means that people are engaged with their health and they are accessing medical care on a regular basis. That includes that they are getting monitored in HIV, in the case of HIV, of their viral load or CD4 count regularly, and that they're on ongoing treatment. They're also picking up their medications and accessing support services as needed. So all of these things really we think about when we think about retention and care, and this goes along with the HIV care continuum or treatment cascade, right? And so, every people spend a lot of time at this end on the diagnosis, right? And we spend a lot of time early diagnosis, rapid ART, all of that linked to care. But this retained and engaged in care, is kind of in the middle. And I kind of think of it as a middle child, It's not quite the sexier part on either end. It's kind of in the middle, right? And so that's the day-to-day work. That's the keeping going. That's, and you just are trying to live and move through, right? And hopefully you keep on moving to viral load suppression, and that is the goal medically. But there's a lot of things that go into each step of this care continuum, and we also know that there's a lot of people who fall out between each step, right? And so when we think about measures, like I'm sure you all have had quality projects that you're working on around retention and care, right? We can think about visit adherence. Are people coming to the visits that they schedule, right? What is the gap that we're expecting? And the HRSA measure is two medical appointments in a calendar year. And so every 6 months about apart, it also lines up with HRSA eligibility. And so for many people, this is a good measure of how they can know that they're engaging in their care. I worked at a clinic where we really like to see them every quarter, so 4 times a year. So, it can vary depending on what your clinical expectations are, but having some measures around this and being able to track this for each of your patient population is really an important part of being able to measure and keep count of this engagement and retention and care. And why does it matter, right? So they've done lots of research on this. Retention and care leads to higher viral load suppression, which can lead to lower HIV transmission, right? We're all trying to use treatment as prevention. And then ultimately, it leads to reduced mortality, right? And so we have already seen that kind of happening with people living with HIV. We're now, working with people in their 70s, in their 80s. I met a young man in his 90s living with HIV. So, these are all things that are possible through this engagement and retention and care process. And wouldn't be who I am if I didn't share a little research with you. So it's also, important for us to think about, what are the visits? What is it really? What goes into it and how is it affecting it, right? So we have noted, this study was done to really know what are the visits needs. So there can be 4 visits a year. I'm sorry about that. 4 visits a year, that would be like optimal. 3 is still good, right? That's still engagement and care. 1 to 2 visits a year still works. No visits in a year is where we get concerned and where we feel like, or what the research shows that, new infections come from people who are not retained in care. And so that's really why this is an important piece, is because we know if people have HIV and they're not virally suppressed, that they can spread the virus. But if they are virally suppressed, they cannot spread the virus. And this is really big news, right? U equals U, undetectable equals untransmittable. And so this research is very solid and has been out for a little over 10 years. Treatment as prevention came first, TASP, but it's all the same thing, meaning that if people are virally suppressed, they cannot spread transmission. But in order to get there, they really have to be engaged in care, right? So, do you all think about who who has stopped coming to care, you know? And again, I invite you to look into the chat. What are some of the reasons or the barriers? And thank you, Pedro, for sharing with us housing, food, mental health, insurance, language barriers. Those can all be big questions in people's lives, right? Of how do I solve these issues so that I can do so that I can engage with folks around my health. Also, what does health mean to people? I think that's one that we don't often ask, but that can be very critical to understanding how people want to engage with us. And it can be as simple as, what do you what does health mean to you, and what does our health engagement mean to you? What kind of relationship do you want to have with me as your healthcare provider? What would be helpful for you? What is not helpful for you? Have you had a provider that you were able to engage with in the past? Those are all good questions to think about as you're trying to engage someone throughout this treatment cascade for HIV. We're going to go deeper into that. But first, I want us to just think about who these people might be, right? So we have a case example of a 23-year-old Black heterosexual male with bipolar disorder who presents at Antelope Valley Medical Center in the ER for an abscess related to skin popping. Are we all aware of what skin popping is? It's okay if we're not. It just means that we're injecting drugs not into the vein, but just underneath the skin. And on a routine HIV screening, this person tested positive, right? So the patient doesn't remember the last time they got tested or the last time they went to the doctor, as they don't currently have insurance. That's why they're at the ER. So what are some of the things that we might want to consider that could put this patient at high risk for loss to follow up? What might make this person not engage in care? And as you're meeting people, this is, kind of the basics of what you might know about them and giving some ideas around, you know, should I be preparing to like see this person regularly, or is this person at risk, and what can I put in place to ensure that they are able to come back to their visits? Right. So, Aaron, thank you. For one, it's untreated mental health. Exactly. So, hierarchy needs survival. Um, they probably feel well, so there's no need to go to care, right? What we would reconnect one um, or when they would like to meet in the ER, because that might be the best place to meet them, right? If they don't have any insurance at this time. It could also be around stigma and denial. Thank you so much, Aaron, for sharing those because those are good ideas. I think what I want to offer you all is kind of two buckets of ideas. One about individual factors, right? So it could be, as Aaron put in there, mental health, substance use, also, age, just being a young person. There are many things going on, including the frontal cortex of the brain hasn't been fully developed. So, just that organization and follow through part sometimes can be difficult for folks just because they're young, right? Also, stigma might be a thing that we need to consider. Also, limited knowledge about HIV. They probably don't know what they don't know, right? And so making sure that could be a barrier to them engaging in care, right? We also have some structural barriers here, including insurance gaps, right, that were named. Also, transportation. How this person get there? All of those good questions. Do they have access to regular transportation? Housing instability could be also be a factor. Financial capacity and health system complexity. And I think we underestimate that health system complexity quite a bit because we work in systems, right? We're used to dealing with phone trees and having to press this button or wait for a half an hour for somebody to actually appear on the phone. But if you're new to the healthcare system and you're trying to get what you're trying to get, that can be a very frustrating process. And so being able to let people know what some of those barriers might be and set expectations with that client can really help in that engagement process and also that building rapport process, right? If you tell the person, I this is a complicated system, um, you're probably going to have to call and wait on the phone for 45 minutes in order to get to a person to talk to. I appreciate that, right? Like we appreciate things like that. We appreciate like knowing what we're getting into. So kind of setting those expectations can also be really important factor when we talk about engagement and care. So these are some of the factors, right, that they looked at, and when we considered the whole treatment cascade for HIV, these are some of the correlating numbers that really tell us that these are some of the things that really affect people's ability to engage, right? So if they don't have access to insurance, less likely to engage, right? If they live in a rural area, there's lower retention in care in rural areas for several different reasons, including provider shortages, changes. These are some of the structural factors, but also it can be far from where you need to go. It could be 2 hours away. That's a huge barrier, right? The southern U.S. has the highest burden and the worst outcomes, which I know many of you are aware of. And part of that is due to many of the structural factors that we just talked about being compounded in the South. And so that's something to also pay attention to. There's also lower retention among Black, Hispanic, and some other non-white groups like Pacific Islanders, and some Asian populations. So when we look across the care continuum, these are quite significant things that we need to be taking into account, right? Also, demographics, like I was mentioning earlier, age, being a younger age can definitely affect people's ability to engage in healthcare. And many times it's the first time that they've had to deal with any kind of healthcare on their own. So that process of teaching is very important for a clinic to provide the structure of how it works. So people know what to expect again, can be super helpful and is a best practice, right? Some of these other ones we already went over, so I'm not going to go through them again, but you all get the picture here. There are things that can be facilitators and things that can be barriers, right? And I think overall, the elephant in the room is that stigma is still alive and well, right? And trust in the healthcare system is still being built and broken and built and broken. And so people can feel like they're in a bit of a roller coaster ride with their engagement in systems. It depends on who they get in the system. Is that person gonna let them know what all the barriers could be and help them through that? Or are they gonna be just like, this is your health, this is what you have to deal with now. Here's some numbers, you should call them. Those are two perfectly, I know, practiced ways of dealing with retention. But the first, that warm handoff, that connection, that building that rapport and relationship has been proven to be more effective than simply handing people off to other parts of the system. And oftentimes people can get lost in that system. So when we think about stigma too, when we're going to different parts of the system, where is stigma? Where might stigma come up for that patient is something to think about and to prepare that patient for. So we talked about what it is, right? Now, what are some of the things, right? This is the part you guys wanted to get to. What are the strategies, right? So the proven strategies are probably things that you've heard of, right? Patient navigators, especially if they're peers or people of lived experience. This has been proven effective over and over again, especially in HIV. The programs were originally developed through cancer research, but quickly adopted by the HIV community and have been in place for a long time in many places. But the professionalization of peer navigators, of peers in general, community health workers, all of these kind of folks who really can engage with that person on a individual basis, maintain personal contact, and provide a combination of education and resources. Those are the components that have really shown in studies to be effective in helping that patient stay retained in care. We also have case management. So there was a study on ARTIS, which is a CDC intervention that really trains new case managers. Maybe some of you all know about ARTIS, right? And that has really been shown that, having a brief um, counseling session at a new HIV diagnosis, not only should it be available, it really helps that person feel grounded and moves them along that linkage process in a way that they are more likely to be maintained in care. So this is a really important aspect to have that introduction of case management as early in the process of diagnosis as possible, right? Having walk-in clinics, so people being able to walk in without an appointment. Also, another study that I was looking at about walk-ins, it was about walk-ins, but it was also about length of appointments. So maybe not the provider can't see the patient for more than 15 minutes, but are there other members of the care team who can spend a little bit more time with the patient, such as a trained social worker or another kind of advocate or interventionist. These can also be helpful to facilitate successful linkage and retention in care. And they lead to a significantly higher proportion of patients attending an HIV clinic in once every 6 months. So having that person that they know they're going to see is very helpful in helping people to come back. Um, Now we're going with enhanced contact, and you might be wondering, what is that? What's the difference between navigation and enhanced contact, right? So, and case management. So there are some very specific things that the and can't contact had. So as I was speaking earlier, they had there was a study based on randomized and controlled trials, and they looked at five tiers to guide. So it was about systematic monitoring of retention and care. So knowing, you know, when the person's last appointment was, all of those good things. That's an important aspect of it. Being able to start medications quickly, rapid start, has also been shown to be very effective in helping people to stay into care, right? Having a relationship with the health department, so that if folks are falling out of care, there is the engagement of DIS and other public health department workers who can help to find that patient and bring them back into care. Um, and I think the other thing is in around record keeping. So the patient might not come back to the clinic that they started out, but can we share enough information that we know that the client is still in the system in our area, neighborhood, in our county, or in our region, depending on what kind of area we're looking at, right? And so being able to have those relationships with other healthcare entities can be really essential to being able to monitor whether someone is actually engaged in care or not. Sometimes we think that people aren't engaged in care and they've simply changed providers, right? And so that is an important part too to make sure, or they've moved out of state, like being able to monitor where people are so that we have accurate measures of retention is super important. And I already talked about Rapid Art, so we're there. So I did want to just show you all how is everybody familiar? I'd love to see a thumbs up. How are you familiar with um data to care models? So this is really about working with the health department. They get all of the surveillance information on HIV, so they know when someone's diagnosed. Um, and they have people who can go and contact them. So they'll have contact with the patient or client, and then they can help to link that patient into care. But if they fall out of care or they need to communicate with that patient, it's meant to be a two-way street, right? That the health department provides clinicians with information, and the clinics also provide information back to the health department so that there is a system of really supporting that patient. Next time I do this slide, I'm going to put the patient right in the middle because this is all meant to help hold them, excuse me, tightly in this care pocket, right? And that's really what we're trying to do with this engagement and retention and care. So I also just want to talk to you all about how do we start these conversations with people, right? So we're wanting our end goal is to help people stay retained in care, but that may not be their goal, right? So how do we even know that? So I'm going to offer some different conversation starters so that we can start to have those conversations. So one is it might be important to you to come to your medical it's important that you come to your medical appointments regularly so we can note your progress and support your efforts to stay healthy. Let's talk about what health means to you. What do you all think? When you think thumbs up, thumbs down, how would you feel if you got this kind of greeting when you first uh, were diagnosed with HIV and coming to a first appointment? I want you all to think about that. We have three to offer, right? I know it can be difficult to keep up with all your appointments, but it's very important. What can we do to make sure that you keep your next appointment, right? Or I'm looking forward to seeing you on a regular basis. Have you ever had regular appointments to work on other health goals? It's asking the patient about how they have engaged with the healthcare system previously can be helpful. All right, so these are for new patients to establish that you really do want to engage with them on a regular basis. I think even just letting them know that can be super helpful for setting expectations, right? So let's say we have a returning patient who comes regularly, right? So you might say to them, "Hey, you're looking well. I'm pleased that you've come in so regularly. What have you been doing to keep yourself well?" Focusing on what they're doing to maintain their health can sometimes help people feel motivated to keep doing those things, right? Thank you for doing such a great job of keeping your appointments. It makes it easier for us to work together and to keep your HIV virus under control and keep you healthy. You could simply just state that, especially if they're doing well, really noticing that they're doing well, that they are coming into appointments is something that can help to build that momentum with folks, right? Thank you, Aaron. I didn't see your comment at the time, but I think you were talking about the previous slide, but that's a great one. Yeah. Thank you. I would also offer an open-ended question. That's great. Great feedback. So let's talk about now the people that, you know, they may not have been so consistent in coming into care, right? So how do you have that same conversation with them, right? So I offer these three kind of conversation starters for inconsistent patients, right? So, you could offer a fact, right? Like people with HIV do better overall when they come to their appointments on a regular basis. How can we make this happen for you? You know, asking the patient what they would need or like, right? And it's an open-ended question. Second one, I need your help to keep you healthy. When you come to your appointments and see me, we can work together to make you as healthy as possible. So it's not quite a question, but it's also offering some support and saying, you know, what the goal is to keep you healthy. And I think that sometimes that offering can be helpful for folks who may not feel like that's what the health system is there for them, right? In particular. Um, Also, the last one, let's talk about what's keeping you from coming in to see me. Putting it out there, just going right in and direct with the patient. You haven't been here so much. What's going on with that? Just finding out and kind of doing it in a way that's lighthearted, open-ended, but also just calls the patient in to have the conversation. What can we do better so that you'll want to come to your appointments? Is it a barrier? Is it a structural barrier? Is it an individual thing? What resources might you use? Might be some follow-up questions to help guide this patient right even further into a conversation that can help them stay retained in care. I would like to hear from you all. If you have any conversation starters that you use with patients, please drop them in the chat and let us know what you all think. What would keep you engaged in care? What are some of the things that you would love to hear from your healthcare provider? Have you heard a healthcare provider do something that you're like, yes, I'm so glad that I signed up with them? Um, for me, one of the great things about one of my providers is they make the next appointment when I leave the appointment. So I already have an appointment when I leave, right? That makes it a lot easier for me to know, oh, I need to come back, right? And so that's one of the things that the evidence shows is helpful is making that appointment before the patient leaves. Also calling them um at least a week before, and it can be closer to the appointment, but as a reminder. A week before is important because it's not the day before. It's not like, oh no, you forgot. It's like giving them enough time to react if they did forget to change any things or anything like that. So that can be another helpful thing that the research offers around what kind of practical things you can do to help people stay engaged in care. Any other thoughts? Actually, looking at the chat, I don't see any. And then, so I'm pretty much to the end. I wanted to offer you all this last video that really t has a patient, a community advisory board member that I have worked with, who really is talking about what he would appreciate from the healthcare system. And I think it's super important to hear from people living with HIV themselves about what they would like the system to do, right? And this is a person who's aging with HIV, and this is from our aging project.
let's also look at how we can refer people to resources where the only qualifier is your age and your money. Your HIV status is not part of the qualifications. So you can go out and be of a certain age and you can get assistance with tax preparation. You can get assistance with how to navigate picking a Medicare Advantage plan. You can navigate understanding what is a Part D and a supplemental plan for people who have been doing this for decades and decades and decades. How about home modifications? Got nothing to do with HIV. Well, I looked up and found an organization that helps people who are living with disabilities and or are 65 and older to get funding for home modifications. Again, let's focus on this person-centered, not HIV-centered approach to helping people live a higher quality of life and for as long as they possibly can, and let them enjoy living.
Thanks so much, Michael. Every time I play this video, I think of him and how important
That's
it is that we really do focus on living, and that HIV is one part of the story, but it's not the whole part. And I really believe that that is what helps people to stay engaged and care. That it's about their whole health. It's about looking at the barriers that they experience and addressing them on a patient level and being able to provide some resources and solutions and strategies as we can, to help them engage and stay retained in care and ultimately reach viral load suppression. And that's all I have for you today. So I'm gonna stop sharing my screen.
Well, thank you so much, Jadon, and thank you, Aaron, for starting us off with a round of applause. So if everyone can give Jadon a virtual round of applause, that would be greatly appreciated. Awesome information. Thank you so much. Now we're going to go into our Q&A. We have a little bit of time for that. So if anyone have any questions, I know we have some comments in the chat. And I will share what we have here. So Aaron is saying, I'd like to provide a summary of what we have covered, what they have stated that they want to do, and by asking what else do you need before you leave. The final question is then focus on what is the plan for returning for the next appointment. Great idea, Aaron. Thank you so much. Others have questions, please feel free to put them in the chat and I'll share them with Jadon. But for the sake of time, I will share some information with you as your minds are spinning and you come up with questions. So there's a little bit of housekeeping to close us up here for our webinar. We greatly appreciate your feedback. Your feedback is very important to us at the CAPTC and with our fellow super providers like the Pacific AIDS Education Training Center. And so if you can take a moment to provide us with some feedback on our evaluation survey, that would be greatly appreciated. You can either scan the QR code here on the slide, or you can click the link that our producer has dropped into the chat, or will drop into the chat in a moment. But yeah, so if you can give us some feedback, it should take you no more than 5 minutes to give us some thoughts on today's webinar. And even though the webinar series is coming to a close, the fun does not have to stop here. So the California PTC, we do host a monthly social determinants of health community of practice with members of the HIV prevention workforce to develop plans that will address social drivers of health and HIV. Our next session is this coming Thursday, March 26th from 12 to 1 p.m. Pacific time. If you are interested, hopefully we can find the registration link. If we can put that in the chat, Louise, that would be great. So that way, if folks are interested in attending our upcoming session for the SCOHCOP, they can. We also provide support to our COP members with our office hours, and our office hours are from Wednesdays from 9 a.m. to 2 p.m. Pacific time. Folks that have any questions about their plans, they can reach out to us with an email to captc@ucsf.edu, and one of our staff members will follow up with you within 48 hours. But that is part of what we have going on this week is our STOH Community of Practice. Just also a reminder, we provide our free TA to CDC funded programs nationwide. If you are directly funded, please contact your CDC project officer and submit a request to the CEBA tracking system, also known as CTS. If you are not directly funded, please contact the state health department in your jurisdiction to submit a request so that they can submit a request on your behalf. And for additional TA, you can also go to our website, CaliforniaPTC.com. You can find our online asynchronous courses and other resources that can provide you with TA in an interim before our next event. Also, we are on social media. You can follow us on Instagram, X, formerly known as Twitter. We're also on Blue Sky, LinkedIn, and we have a quarterly newsletter. You can find all that out on CaliforniaPTC.com. And that is about it. But if anyone has any questions for Jadon, we just have some love in the chat saying thank you for the great presentation. But anyone
Thank you
have
all for attending, and thank you to the California Prevention Training Center for inviting me. This is a topic that I love to talk about, so I really appreciate you all and playing along with me in the chat. Aaron, appreciate you, and several others who participated in the chat. Always makes it more fun.
Thank you so much, Jadon, and thank you everyone for supporting our webinar series for the last 4 weeks. This has been a fantastic learning experience, and we are hopeful that you all have some great ideas and strategies over the last 4 webinars to help your populations of focus get closer to zero. So with that being said, I would like to thank you all for supporting our webinar series. We look forward to seeing you at our next event. Thank you again, Jadon, for the wonderful information and presentation. And we will hope that you all have a great rest of your day and week. Take care, everyone.